All right, we're back with Dr. Wilcox, who's going to join us to discuss valvular heart disease as another etiology of heart failure syndromes. Dr. Wilcox.
Thank you so much, Dr. Schweitzer, and thanks to the rest of the organization for inviting me to speak with you today. So we'll get right into it. I have no relevant disclosures to this talk. So the objectives of today's talk will be to discuss the management of primary and secondary MR in heart failure patients. I think we'll focus primarily on functional MR, as it's been an area, it's a hot topic with the results of 2 clinical trials that, while they're not incorporated in the guidelines yet, I think they could be fair game for boards, especially for some questions that they may be testing out. We'll discuss aortic valve disease in heart failure. Specifically, I think the hot topic here is going to be low flow, low gradient aortic stenosis. We'll talk about AI briefly. And then finally, we'll discuss tricuspid regurgitation in heart failure. So there's lots of clinical trials that are on the horizon that are currently going on, probably at most of your institutions. And we'll talk about the prognosis and the management of these patients. So if you're like me and you feel like you're constantly seeing mitral regurgitation in our heart failure patients, it's because you are. Up to half of the patients with low EF that we take care of will have greater than or equal to moderate MR. And the 2 flavors of our MR that we see primarily are restricted motion of the posterior leaflet associated with prior myocardial infarction, or ischemic MR, and LV dilation due to non-ischemic cardiomyopathy, which impairs leaflet coaptation and leads to flattening of the mitral annulus. Because these changes are really dependent on loading conditions and the phase of the cardiac cycle, secondary MR is really dynamic in nature, and we see this clinically. Now, secondary MR or functional MR is a powerful predictor of death or transplant, even in patients with less severe heart failure. And this is a fantastic review article by Greg Stone and colleagues, which I encourage you to take a look at. And they highlight here that there's a 50% survival at 3 years among heart failure patients with severe functional MR due to ischemic cardiomyopathy. That's right here. And a 50% survival at 4 years among non-ischemic patients. So for boards, I could see a test question related to the impact of severe MR on mortality for heart failure. Now, when we're thinking about correction of primary MR, it's really, so this is a valve problem, not a ventricle problem. It's really driven by symptoms and changes to the LV, like progressive LV dilatation or drop in LVEF less than 60%. So when thinking about surgery for primary MR and LV systolic dysfunction, the key cutoff point in the guidelines is an EF of 30%. That's here where the recommendation, it goes from a class 1 recommendation, level of evidence B, to a class 2B recommendation, level of evidence C, because historically outcomes are very poor with significant LV systolic dysfunction. And this is where conversations with the heart surgeon and heart failure cardiologist are very important, as we all know. And accordingly, the heart team approach is a class 1 recommendation in the guidelines. So this is just similar data presented in a different way for more visual learners. And again, here, this sort of key cutoff to know is an EF of 30%. So I might imagine a question where a patient has primary MR, they maybe were lost to follow-up, and their EF is 40%. It's still a class 1 indication to undergo mitral valve surgery for repair. So what about mitral repair for ischemic MR? So this trial reported 2-year outcomes of patients with at least moderate MR who were undergoing revascularization to either CABG with mitral valve repair or CABG alone. So do you fix it or do you just revascularize it? And patients with mitral valve repair were less likely to have greater than or equal to moderate MR, and there was no difference in mortality or major adverse cardiovascular events, and there was no difference in LV remodeling on echo. However, neurologic events and SVT and AFib were higher in the CABG plus mitral valve repair. So it really still remains uncertain about what to do in the guidelines, and it remains a 2B recommendation in the 2017 updated guidelines. Now, you'll talk to a lot of us clinically and we'll say, well, this is only 2-year outcomes of patients. And so I think, most of the time when the surgeon is going in, he or she, sees moderate MR, really it's hard to ignore. And most of the time we'll fix it. So that brings us to our first audience poll or audience response board question. So we have a 60-year-old woman. She's presenting with progressive dyspnea on exertion and fatigue. She was diagnosed with dilated cardiomyopathy 10 years ago and has been hospitalized for heart failure 3 times in the last 6 months. She is now only able to tolerate 2.5 milligrams of lisinopril, historically has been on 20 milligrams, 25 milligrams of toprol XL, again, historically 100 milligrams, and 25 milligrams of spironolactone. On exam, her vital signs are blood pressure 80/60, heart rate 78. Her jugular venous pressure is 8 centimeters of water with a summation gallop, with an S3 gallop. And her echo shows an LV end diastolic dimension of 7.8 centimeters, EF 18%. And she has severe holosystolic functional MR and moderate RV dysfunction. What is the next appropriate step in management? Is it MitraClip for severe MR, right heart catheterization and cardiopulmonary stress test, C, refer for mitral valve replacement, or D, not 2 C's, or D, start 100 milligrams of torsemide daily? So we'll start the countdown. Sorry, I should have started it earlier. 5 seconds left. Hopefully you all get this. All right, good. So change your vote now to B. So the answer here is B. She is approaching and likely has stage D heart failure. So progressive symptoms, long-standing dilated cardiomyopathy, down titration of meds. So surgery for MR or MitraClip will likely worsen her clinical status, given her very dilated LV, almost 8 centimeters, and moderate RV dysfunction. And so we'll talk about this in the coming slides, but I think this is where the COAPT trial and MITRA-FR could be, fair game. So the COAPT trial really enrolled a unique population of patients with really out of proportion functional MR, not progressive stage D heart failure patients. And so this patient should really be referred for advanced therapies, which includes a right heart catheterization and a CPET as part of the workup to determine her transplant candidacy. While I love diuretics, as you all do as well, I bet, but her JVP is only 8 centimeters of water. So high dose torsemide doesn't really seem appropriate in this clinical STEM. So let's talk about the 2 trials that sort of still, I think on paper, create equipoise when we're thinking about functional mitral regurgitation and what the right thing to do is for our patients. So on the left here, this is the MITRA-FR trial that was conducted in France. And the right here is the COAPT trial that was conducted in the United States and Canada. And you can see here that the Kaplan-Meier curves look very, very different, with no difference in the control group and the intervention group with MITRA-FR. And we all know that the COAPT trial was indeed positive, which showed a significantly lower rate of hospitalization for heart failure at 2 years, which was the primary outcome, and significantly lower all-cause mortality at 2 years, which was a secondary outcome in the device group. And I think the key point, the key difference between these 2 trials and the outcomes was really the population that they enrolled potentially, and also how those patients were treated. So in the in the MITRA FR trial, enrolled 300 patients, mean age 70, EF 33%. And here, similar, mean age was about the same, EF 30%. The difference in the COAP trial is that patients had a heart failure specialist and overall had more functional mitral regurgitation in the face of guideline-directed medical therapy. And so about 900 patients were actually screened out of the trial. I remember presenting patients on the call to see if they could get enrolled. And, to the heart team's credit, they said, go back and increase the hydralazine and isosorbide dinitrate. This patient is not yet on guideline-directed medical therapy. And oftentimes, with GDMT, the severity of the mitral regurgitation would decrease. And so the key difference here is that they had greater than or equal to 3+ MR despite optimal medical therapy. And so accordingly, when we look at, these trials were published after the guidelines, but they really took into consideration that for secondary MR, the first order of business is that you treat the ventricle. So treating with guideline-directed medical therapy for heart failure, revascularization, if there is an ischemic component, consideration of CRT before moving to a device intervention. And so while the 2017 guidelines here have mitral valve surgery still as a 2B recommendation, I think clinically how we're treating patients is if they do have that functional mitral regurgitation that is out of proportion to the ventricular performance or the ventricular dysfunction, those patients would do best with the MitraClip or for their treatment of their MR. So let's move on to aortic stenosis. So aortic stenosis is pretty simple when you think of just severe aortic stenosis with normal ventricular function. You have symptoms and you go ahead and get your surgery. The key point here is that if you have an EF that drops less than 50%, this is a class 1 recommendation for AVR. But this brings us to our second board question and what we'll talk about in the next slides. So we have a 65-year-old man with known ischemic cardiomyopathy presenting to your clinic with progressive shortness of breath and volume overload. The echocardiogram shows a heavily calcified aortic valve with reduced excursion. The mean gradient is 25 millimeters of mercury. Peak velocity is 3.4 meters per second. Aortic valve area is 1, and LVEF is 20% with moderate MR. What is the next best step in the management of this patient? Should you refer for AVR and MVR with cardiothoracic surgery, perform a low-dose dobutamine stress echo, enroll in the TAVR unload trial, or perform a right heart catheterization? Awesome job. Great job. So this is where the heart team, the heart failure doctor comes in and recommends this test. And so let's talk a little bit about the flavors of aortic stenosis. So this is pretty straightforward here. Normal EF, normal flow, high gradient, straightforward aortic stenosis. I don't think this is going to be on boards here, this normal EF, paradoxical low flow, low gradient aortic stenosis. This is where the EF is greater than 50%, but there's a low stroke volume index. I do think this is where we're going to spend some time talking, but I do think one question might come up where you have a patient who's got paradoxical low flow, low gradient aortic stenosis, and they're hypertensive at the time of their exam. And so you need to make sure that their low flow isn't due to afterload mismatch and that their systolic blood pressure is less than 140. But when we're looking at this is sort of the classical low flow, low gradient aortic stenosis. And so if you have a patient who presents with that stem, the mean gradient is not quite 40, E is 20 to 39. The max velocity is between 3 and 3.9. Again, doesn't quite meet criteria, but does have symptoms. And the EF is less than 50%. Proceed with the dobutamine stress echo. So low dose dobutamine is given and can really help determine whether the AS severity is severe or only moderate. And it's also used to evaluate for contractile reserve in low flow, low gradient aortic stenosis. So just as a review, dobutamine is infused in progressive stages, beginning at 5 mics per kilogram per minute, and it increases in increments of 5 to a maximum dose of 20 micrograms per kilogram per minute with appropriate clinical and hemodynamic monitoring. And so the ASE and the ACHA guidelines define severe AS on low dose DSE as a maximum velocity of greater than 4 meters per second with a valve area less than 1 at any point during the test protocol. So you might also get a sneaky test question that says, they reached it, but then it went down, went up and down, something like that. At any point in the test, if you reach that, they truly have anatomically severe aortic stenosis. And then this is more the low flow paradoxical normal EF patient, where it's again a 2A recommendation for aortic valve replacement. Now, I mentioned that the low dose dobutamine stress echo with either or invasive hemodynamic measurements is recommended to determine whether or not patients have severe symptomatic low flow, low gradient AS, but it's also used to determine if patients have contractile reserve. And this is sort of a landmark paper from Circulation in 2003 that looked at survival of patients with low EF who had low gradient aortic stenosis according to the presence of low flow reserve and the type of treatments. And you'll see that patients with no LV flow reserve or contractile reserve, it's really flow reserve, what we all call it contractile reserve. So those are patients in group 2, and that was defined as a less than 20% increase in stroke volume during DSE. They have really markedly reduced survival compared with those who did have LV flow reserve in group 1, regardless of the type of treatment. Aortic valve replacement was associated, obviously, with a dramatic improvement in survival with patients who had LV flow reserve and a trend for better survival in those with no flow reserve. I think all of us clinically still would offer aortic valve replacement, usually with TAVR in these patients, but it's important to have a risk-benefit conversation with your patients. Now, newer data from the TAPIS TAVI registry included 287 patients with low flow, low gradient aortic stenosis who underwent TAVR. And DSE was performed before TAVR in 234 patients. And the presence of contractile reserve was defined again as having that increase in 20% in stroke volume. And then they repeated the echo at hospital discharge and a year follow-up. And you can see the clinical results here, where there was really no, 1/3 of the patients with low flow, low gradient AS who underwent TAVR, they died at the 2-year follow-up. This is a very sick population. Average age in this population was 80 years of age. And as you might surmise, on multivariate analysis, outcomes were really associated strongly with comorbid conditions like pulmonary disease, anemia, and residual paravalvular leaks were also associated with poorer outcomes. Now, interestingly, EF improved following TAVR, but dobutamine stress echo really failed to predict clinical changes in EF or clinical outcomes, including mortality over time. And there was a sub-study of very low EF patients where they had an EF less than 30. And again, that held true where the dobutamine stress echo did not, those results showed really no effect or were not associated on a clinical outcomes or changes in EF over time. And so this is, I love this slide because when I started training TAVR, we all lived through the PARTNER 1, 2, and 3 trials, but TAVR is a class, is really approved for all categories of severe symptomatic AS, and really is only a 2A recommendation in intermediate surgical risk here. And this is updated from the 2017 guidelines here. So a couple slides just on chronic aortic insufficiency. I can see that, we can see, I think the bulk of the questions are probably going to be around low flow, low gradient aortic stenosis and functional mitral regurgitation. But I could see a stem here where a patient has an EF of 30% and chronic AI, and it is indeed a class 1 indication to proceed with aortic insufficiency. I think all of us, as we clinically take care of these patients, if you have a patient with an EF of 10% and chronic AI and a very low cardiac index and some end organ dysfunction, this is where we would have a heart team approach and think about, do we replace the valve and do VAD as backup, or do we go right to VAD? And these are sort of some nuanced questions that I think probably will not make it to your boards. As such, this is a slide from the Mayo Clinic experience with aortic valve replacement for AI in 450 patients. And you can see that, outcomes with a lower EF are worse. But again, usually we will offer this surgery to patients despite a lower EF to try to, quote unquote, kick the can down the road before they need a VAD or or a transplant. So I'd like to finish up here with the forgotten valve, the tricuspid valve. So there's lots of, clinical trials going on in this space. It's super exciting. But for your boards, I think that the thing to really focus on are that, functional tricuspid regurgitation accounts for 80% of cases. And that's in nature. And that's really related to tricuspid annular dilatation and leaflet tethering in the setting of RV remodeling due to pressure and volume overload. So remember, the tricuspid annulus is this saddle-shaped ellipsoid, and it really will often not return to normal despite the relief of RV overload. And you'll see in this study by Nath and colleagues that the severity of TR is obviously associated with poor outcomes with moderate to severe TR with very low survival. And so just sort of a marker of badness. Things to watch out for on the boards would be primary tricuspid regurgitation due to things that we do, right? So RV endomyocardial biopsy related trauma, intraannular RV pacemaker or ICD leads. Again, that only accounts for, less than 20% of tricuspid regurgitation. The vast majority is functional in nature. And ongoing clinical trials, I think, will not be tested as part of the boards. So indications for tricuspid valve surgery, really just if you're undergoing left-sided valve surgery, if you're in there, a lot of surgeons will put a ring on it. This is level of evidence C. This is the only class 1 indication for tricuspid valve repair in the guidelines. So in summary, our pearls for boards, class 1 indication for MVR and primary MR when the EF is between 30 and 60%, even if asymptomatic. Out of proportion functional MR. So these are patients who were enrolled in COAPT, high dose guideline directed medical therapy. So after you have high dose GDMT, if you still have 3+ MR, those are patients who will do well with the MitraClip. For aortic stenosis, low dose DSE with echo or invasive hemodynamic measurements in the cath lab is a class 2A recommendation for severe symptomatic low flow, low gradient to evaluate that and contractile reserve. I think newer studies showing that contractile reserve may not track with outcomes and that patients should be offered TAVR in a shared decision-making process, but really no matter what, is not in the guidelines yet, but could be fair game. And then finally, tricuspid valve is really only in tricuspid valve replacement or repair is really indicated only for concomitant LV surgery. And our medical therapy for patients with severe TR and RV dysfunction is really limited to high dose diuretics. And I will often use mineralocorticoid receptor antagonists, spironolactone, and eplerenone. So I'll finish and happy to take questions at the end. Thank you.
Great, Jane. Thank you so much. That was really a beautiful overview. I think valve disease is such an exciting area, and probably 10 years from now, the boards will be very different in this area as trials continue to accumulate. You also got us almost back on time, which we're very grateful for. Not a lot of questions have come in. So I'm going to ask you one question, which is unlikely to be tested on the boards, but just from a practical clinician standpoint. We have so much multimodality imaging available now. Can you just hit on the mitral valve, the aortic valve, and the tricuspid valve and talk about when you suspect disease that needs intervention, which modality do you like to use for each valve?
Perfect. So I'll start with the mitral valve. I think the guidelines actually mention this, that TEE and transthoracic echocardiography are complementary. So TEE is really going to define the leaflets and help us to determine how we're going to fix the valve. What's the leaflet height? What are the measurements? And is this patient, going to be an appropriate MitraClip candidate? Transthoracic is really a great screener, but as you know, can really miss and underestimate posterior MR MR that's posteriorly directed. And so TEE really becomes sort of our workhorse there. In aortic valve, I think transthoracic, especially when you're doing the dobutamine stress echo, getting that suprasternal, using the pediatric or the PEDOF probe up in the suprasternal notch can help get the higher velocities sometimes when you're not able to get good windows. Less so we're using TEE in this space, but really transthoracic. And you can also use, we do CT in these patients, right? A sort of a TAVR planning CT to grade the amount of calcification. And that can sometimes help if you're really not sure, is this, severe or pseudo-severe? If there's heavily calcified valve, that can help push you one way or another as well. I think, oh, sorry, go ahead.
Go ahead, tricuspid valve.
Yeah, and the tricuspid valve, I think TEE is really helpful there. A lot of times also we're looking, using cardiac MR to look at the right ventricle a little bit more to see if there's, kind of what's going on and what are the volumes there if there's really severe RV dysfunction. And then for a lot of our clinical trials, we'll use CT to get more annular measurements.
And with the tricuspid valve, in our population, a lot of TR is related to device leads. Do you find any modality particularly helpful in terms of defining impingement due to a lead issue versus annular dilatation and RV remodeling?
We use TEE a lot for annular. I mean, if we can get good windows, we use TEE to figure out, and usually we'll also use 3D echo with TEE to figure out exactly which leaflet is impinged. So I think that's probably the workhorse for the device complications.
Yeah, but sometimes because it's the anterior structure, you just can't get the windows on TEE that you want. It's really a challenge, I think.
It's very, very challenging. And then they have a device, and so cardiac MRI, we will do device, depending on your institution, you'll use cardiac MR, but it is a tricky, I agree, is a really tricky ventricle, tricky valve.
All right. Well, thank you so much, Jane, for a great whirlwind tour of the valve issues in a heart failure population. And we're going to close this and move back to the other room for pulmonary hypertension. Thank you.